So I'll just introduce myself. My name's Anita Green. I'm a general practitioner and I also work at Prince Charles Hospital, have done for more than a couple of decades. And Gurudev, our geriatrician, has just reminded me that when he was a resident there at the hospital, I had the honour of showing him a couple of stress tests. So it's been a long time. So I love the fact that I have the opportunity of working in both camps. And I guess that's what today's also about, is the fact that we've got this wonderful synergy between the health and hospital service and the primary health network, and both the primary care and the tertiary care sector, and that intersects very heavily with our residential aged care facilities. And can I tell you, I think that we have the best relationship between a health and hospital service and a primary health network in the entire country, and it is certainly the envy of most of our colleagues around Queensland, so we're very lucky there. So thank you very much, Bonnie. The others are Ms Janet Morganti, who's Quality and Compliance Manager for Wesley Mission, and Gurudev Kawalram. Gurudev is the geriatrician who's actually been obviously driving a lot of this, along with many other colleagues, to try and get this up and running for the geriatric outreach service. And Gurudev is a geriatrician at Prince Charles. Rhonda Mead, who's the nursing director at Prince Charles Hospital for internal medicine services. The members of the Geriatric Outreach Assessment Service themselves, and also there's other staff here as well from the Prince Charles Hospital, yes. Also, there's another number of other medical and aged care professionals that may have joined us here as well. There's a wonderful staff that we have with our primary health network as well. So Simon, who's busy, Simon's like the wedding photographer. Simon will be popping up and down. Very previous. Simon's our information and media officer at the PHN, and he always makes the rest of us look good. And also the wonderful residents that we've got here at Weller Gardens here. It's fantastic to have so many of you come and join us here for lunch, and also to hear the service that's going to be made available, hopefully, to the residents, that's the reason we're actually here. Not so much just chatting amongst ourselves. It's actually about what difference can we actually make for your care, both at the residential aged care and hopefully avoiding you having to go down the road, it's not very far, but down the road to the Prince Charles Emergency Department. So first of all, I'd just like to pay my respects to the traditional owners, the Turrbal people, and we're meeting on their land to pay respects to them, their past, present, elders past, present and emerging. Now, one of the joys of being the chair of the PHN is to actually come to these sort of events and actually meet the community, meet the people that we're meant to be assisting. We don't do anything by ourselves, we only do things through partnerships with other clinicians, with primary care practitioners and with hospitals, etc. So we're there, I guess, to facilitate things happening, and it's wonderful for me to be able to step out of my clinical role at in the primary care sector, in general practice and also the hospital, to actually change some systems, because I think clinicians are often the best people to see how we can make changes. And Gurudev, that's exactly what you've done and your team have done, is to try and see where there's a problem, an issue, some way we can actually manage these people's care much better. There's a lot of other good work that happens across the region, and it's great for this is just one of the examples of what can be done when we actually we talk together between both the tertiary and the primary care sectors. Now, back in October, the Primary Health Network, Brisbane North Primary Health Network, PHN as I'll call it from now on, organised a workshop just down the road here at the Kedron Wavell Club. And at that workshop, there was a meeting with the managers and staff of many of the residential aged care facilities in this region, as well as hospital and community sector staff, to look at how we might do things better, improve systems of care. And there are a lot of great ideas that came out of it. However, the really interesting response that we got from particularly the RACF, the residential aged care facilities, was give us an accessible medical outreach service. So that's why we're all here today, because that's the work that's been done. And the idea is obviously not new. Has been work done around this at Redcliffe Hospital. However, the difference here was that it came from from all the sectors, I guess, not just the two sectors of primary care and tertiary care, but also from the residential aged care facilities themselves. And that's when things actually work, when it all comes from the ground up and people actually get together to solve I guess, a clinical or a social or a community issue. And the idea of this is to fund a program that will allow us to prevent residents such as yourselves from having to unnecessarily go to hospital. I'm sure you much prefer to be staying in this place, and I've only first time I've been here, so I apologise, but it's a wonderful space out here with trees and gardens, and having us come from the bowels of the Prince Charles Hospital, which is what the ED's like and my area is like, where there's no windows and no trees. It's much nicer to be staying here, to be cared for by the staff that you know and you respect, than have to go to another place and feel with foreign staff, with people you don't know, with spaces you don't know. So the idea is that we can keep you here to be managed for hopefully any condition that's possible, rather than you having to be transferred to an emergency department or to a hospital ward at Prince Charles. Now, according to the Australian Institute of Health and Welfare, there are nearly 3,000 potentially preventable hospitalisations per 100,000 people in our Brisbane North region. And we know that there's been about a 22% increase since 2012. So in the last 4 years, a 22% increase, almost a quarter increase in the number of patients who come from residential aged care facilities who present to the Prince Charles Emergency Department. And that's an enormous increase in their workload and their ability to look after those people. And that's an average of about 100 patients per month. And in January, it increased to 147 people in 1 month. Now, that's obviously an unsustainable issue for their health services, but it's also not the place where you want to be cared for, and that's the most important thing. So that's the reason for the geriatric outreach service. Now, GPs and the residential aged care facilities and nurses do a wonderful job looking after patients here, and they also, Prince Charles does a wonderful job caring for patients when they're there, but we would much rather that people were cared for here, where they're known by their doctors, by the nurses who care for them in the wards, rather than transitioning to the care in the tertiary sector whenever that's not necessary. So it's wonderful to work in a partnership between both the Prince Charles and the GPs and the residential aged care facilities to actually achieve that aim. Now, I'm going to have shortly a couple of other people speaking to actually explain how the service is going to work, so I won't touch on that at the moment. But it's been going since the 12th of June, so only a couple of weeks. And when I spoke with Michelle this morning at the PHN, she told me that they'd received we had numbers for about 20 referrals, but Geriatric may have some updated numbers. And I think that all of those people have been able to be, most of them have been able to be managed by remaining in their residential aged care facility, not being transferred, and all of them have been considered to be potentially preventable referrals to the ED. There were a couple of people who did need to go off to the hospital, but what happened with those people is through the geriatric outreach service, rather than those people, so individuals, residents like yourselves, having to go and sit in an emergency department, sometimes for several hours and sometimes more than several hours, and have all the noise and the bustle and the activity happening there, they were able to be fast-tracked straight through to the ward, rather than actually being sitting around in the emergency department while someone worked out how they should be best managed. So it's been a success from the start with small numbers, and we're hoping that's going to obviously build, and I'm sure it will. So we've also had really good feedback from some of our GPs. One of the GPs who had one of those 20 patients was in his practice. He was unable to leave the practice with a busy practice that was fully booked that day. The residential aged care rang him. They contacted the service. The service then sent out nursing staff to come out and actually insert a drip, give fluids and antibiotics for someone with a urinary tract infection, and that resident was able to stay in their own residential aged care facility and not have to be transferred, so treated where they live rather than in a foreign place. And so we're hoping that there's going to be lots of positive stories like that coming out of the program. So without further ado, I'd like to offer my congratulations to Geriatric and his team and all the Metro North Health Hospital Service team, senior nurses, the administration, and all the clinicians that have actually been involved in getting this up and running. I'd also like to thank the HHS for supporting it, which is the board and the CEO, so Ken, our lovely Ken, who unfortunately has just left us. But so at the senior level, that they support these things as well, which is how things get up and running. And also the medical and nursing professionals at the residential aged care facilities, the GPs who are buying into this as well. And hopefully we're going to have a wonderful service that's going to be available to all of the care facilities in the Prince Charles and the Metro North region. So thank you very much. And now I'd like to pass on to Rhonda. So Rhonda Mead. Rhonda is Nursing Director from the Internal Medicine Services of Prince Charles Hospital. She's going to tell us a bit more about GOAS, if we're calling it now.
GOAS.
It's GOAS. That's right. Thank you.
Thank you. Good afternoon, everyone. Firstly, I'd like to thank Wesley Mission for having us here and putting on this lovely afternoon for us to launch our new service. And again, welcome our board member and our TBCH exec. Welcome to our PHN partners, our GPs, our QAS representatives, our residents and our GOAS team. Thank you to everybody for coming. The concept of... Sorry. The Primary Health Network. So the concept of our geriatric outreach assessment service has been a dream for many of our staff at Prince Charles for a very long time. So seeing it come to fruition is very exciting and it's a very rewarding experience. Prince Charles is renowned for its involvement in the care of the older person, and our staff are very passionate about the provision of high quality standard of care to this population of patients and to maintaining that continued support beyond their hospital presentations. The present model that runs for our residential aged care facility residents when they become unwell is that they present to the hospital setting, often via a Queensland Ambulance Service ride, and they arrive to a busy emergency department that by nature is focused on acute resuscitative models of care and not ordinarily geared to the older person. Whilst they do receive excellent care in our emergency department, the absence of that expert geriatrician input and specialised nursing teams that intervene in their care in the early part of their journey often leads to delays in managing them appropriately for their specific requirements and increases their risk of complications. So a bit more data, which I think you've already touched on. No, that's okay. So a bit of background to our service, that there are currently 2,572 residential aged care facility beds within the Prince Charles Hospital catchment, and this number is growing. This increasing number of older persons in these facilities has resulted in an increased demand for the acute hospital medical services and resources, and this does impact on our patient flow, as you mentioned, within the ED, as well as the inpatient areas of the hospital. Prince Charles is feeling the impact with that increase in presentation. So in 2016 we had a monthly average of 96 patients presenting, with a steady growth of 5% of presentations through the emergency department, and 1 month already this year we've had 147. So as you can see, it's going up all the time. Of those presentations of the older person from the facilities, 46% of them have deemed to be hospital avoidance admissions. So they're spending an average of 2.05 days in our facility when hopefully we could have had them at home enjoying life as normal. The identified target population of these patients are also spending about 450 minutes in the emergency department on average. So that's time wasted for you and time better spent in your own environment. So the intent of this service therefore is to eliminate that unnecessary transfer and the disruption to the lives of the residents, and to support the residents, their families and significant others to receive the appropriate care, and to support the GPs and the residential aged care facility staff to provide that acute care back in their own setting and to ensure the best clinical outcomes for their clients, whilst we respect your wishes to remain at home and have that choice to remain at home. So the benefits of this model is to primarily allow residents to remain in your own familiar environment and to receive appropriate care without having to expose them to the complex journey that our healthcare setting will offer you should you have to venture that way. It's well known that this group of people are more vulnerable simply due to being aged, and they have potential to be frail, have altered levels of cognition and have multiple other conditions. So when you become unwell, there's also that increased risk when you present to the hospitals of being exposed to conditions such as delirium, an increased risk of having a fall or developing pressure injuries, and that deconditioning and having to rehabilitate you and get you fitter to get home. So we are very excited about having all those outcomes and having you back in your favoured setting. Recruiting to these positions has been an honour. The clinical nurse positions that we've put into this model have just exemplified what our Prince Charles nurses are all about. I've had such large interest in the role. Even since it's been appointed, people have come to me since, and they're looking for opportunities. They're very passionate about seeing the care and commitment to the older person continue through this community. So in support of our Metro North focus on the Year of the Frail Older Person, We have levels of support, as you mentioned, from the board right through our executive right down to ground level. So it makes us quite benefited in that we can implement these models and be fully supported in the work we do on a day-to-day basis. Should our residents need to present to the hospital, despite our best efforts to keep you at home, just be reassured that there's more work going on in Prince Charles as well for those who are presenting and need to be hospitalised and need to be assessed in the emergency department, that we do have a focus on the older person and streamlining your pathway through the emergency department and to the inpatient areas, and a definite focus on getting you home early. So thank you very much for having us today and for helping us assist this amazing service.
Guridav is the geriatrician at Prince Charles, is a geriatrician at Prince Charles, not the only geriatrician, and this has been a passionate area for him to work on to actually get this to fruition. So I'll let you tell the story, but it's over to him and his team that have got this up and running. Thank you.
Thank you, Dr. Green. Good afternoon, everyone. Firstly, thank you to Vella Garden for providing this lovely venue. It makes it all the more special to have this launch here. Our primary healthcare network, who will be our partners in having this service launched, the executive board from Metro North and Prince Charles, and last but not the least, my team that's been there. I cannot take credit for this. This has to go to my team. One of the facilitators in the team, Veronica, who's here somewhere. We've had this conversation in passing at the desk when we've been seeing the older person from an aged care facility about 6 or 7 years ago. So this concept has been there from that time. We've been fortunate that we've been able to realize it now with help from our partners, and that makes it even more special. Our success story is from this aged care facility itself. Our first patient has been from this facility, whom the nurses came out to see, treated him here, and 24 hours later, the appreciative phone call that we got back was the icing on the cake. I don't think there's anything else more that I can ask for. It was a few hairy hours that our nurses had to go through, thinking that this patient, normally they're used to inpatient management, had to be managed in the community, but I think they held on their nerve, supported me, and were quite excited themselves with the outcome. So that's where this concept has come in from, that we are not providing an adequate service to our older, frail population who are living in a residential aged care facility, which is their home. We have services which are out there in the community to provide the same kind of service in their own home, but we were lacking this. However, this gap is now being filled. We're hoping to have many more success stories since our soft launch about 2 weeks ago. We've seen about 20 odd patients. We've prevented 9 hospital admissions. We fast-tracked about 6 of them through emergency into the appropriate care, whereas a few of them needed to be in emergency for a little bit longer. With the introduction of our new service in emergency, we will be focusing more on the older person to get them in a better environment, thus preventing all those complications that Rhonda has already mentioned. We work in partnership with the GP. We come into the aged care facility with the consent of the GP or the Queensland Ambulance Services, who may have assessed someone and initiated some treatment and felt that our service would be able to do that, or the after-hours GP who's assessed the patient and felt that yes, we can manage them here tonight, but the outreach team can come and see them the next day. Our aim is to see the unwell person in their home either on the same day or the next day. There is no delay of more than that. That's where we are. We have 2 clinical nurses, one who will be focusing on providing education and one who will be accompanying the registrar in coming out to see them. We are also starting what is called telehealth facilities, with the result that the registrar at the bedside of the older person can dial in and speak to me directly, where I can ask a few more questions, do a few more assessments, and possibly get the best care. If we deem that the person needs to go into hospital, we can bypass the emergency department altogether, getting them up to the ward, thus minimizing their transition through the hospital. As Rhonda has already pointed out, the emergency department is built to deal with real acute emergencies. And sometimes our older person is not in the right environment. That environment may not be conducive for their best outcomes. And we'd like to fast track them through that place so that they're in the right place and that emergency can deal with what they are meant to deal with. So bringing all these services together, obviously we work closely with the emergency department, with the external service facilitators, with other services that are there in the community. Now, if we deem that somebody needs more intravenous antibiotics, we can refer them to a hospital in the home straight from here without them having to come in through hospital and go through the whole process of getting that done. So in the end, being treated in your own home is far better than being treated in the hospital. Some conditions may require transfer to hospital, and we will facilitate that to have a better outcome. The success of this service is dependent on the team. I am just a small part of it, and I'm thankful that I've had that opportunity to do it. Thank you.
Now, I'll get this right. Sorry. So Janet Magani. Janet Morganti is the Quality and Compliance Manager at Wesley Mission, Queensland. And thank you again for hosting us here. It's a fantastic place, and it's great for me to actually see how wonderful the facility is here. It's fantastic. I've got to get outside the confines of my practice and my hospital. And she's going to provide some perspective on the benefit of this for the aged care providers. So thanks, Janet.
Thank you very much. Despite our wonderful infection control measures and procedures here at Wesley Mission Queensland, most of our management team were taken out with the flu this week, so I'm the only one left standing, so I'm here today. But I am delighted to be here to help launch this service and to be able to speak about the benefits from the perspective of aged care facilities. We have 13 aged care facilities across Brisbane and 4 services here on site at Weller Gardens that will be using this service, and also our brand new facility, 144-bed facility, which is John Wesley Gardens just down the road. So I see the managers and staff from all of our aged care facilities here today, so we're really welcoming this. The comfort and wellbeing of residents is our primary concern, and anything that promotes wellbeing for the residents is supported by our organisation. At Wesley Mission Queensland, we take pride in our ability to offer care and compassion while promoting choice and independence, and this service further enhances choice for all the residents who live here. It offers the residents and their family the choice about the delivery of care so that they don't always have to be transported to hospital, which if that can be avoided, that's always a good thing. This enables the care to be conducted in the aged care facility in the surroundings that are familiar to each resident, so that their family can be here, the staff that they know well, and also just the general physical surroundings are familiar to them. Here at Wesley Mission Queensland, innovation is one of our 7 core values, and I'd like to say that we embrace innovation, and so we really embrace this service, and therefore we pride ourselves on being early adopters. So we've already used the service, and I was just told before, and I believe it's true, that not only have we used it, but we were the first facility to use it. So we're very proud of that. The outcome for that particular resident, I have heard, has been very positive. The staff were delighted with the follow-up, and the resident is happy, so you can't get better than that. It's wonderful to see these collaborative support networks created in our communities, which can only benefit each and every one of the aged care residents who live here. Ensuring that each resident receives the right care at the right time, in the right place, can only bring about better healthcare outcomes for each resident. So thank you very much.
I don't need that now. So that's the end of our formal proceedings, unless there are some more excellent questions. Better than some of the students who can't come up with questions. That was fantastic. We still haven't defined geriatric. Is that a problem? No, come on. Yeah, I'd answer. A question at the back, yes.
Go through the referral process for us so that
Okay.
we know.
Would you like to do that, Drew?
Thank you. With our referral process, as I mentioned, it is from the general practitioners. The residential aged care facility can call us if they've got permission from the general practitioners. We have one number for the moment which is integrated with our other project called the GRACE project. That's the access for our community residents into the clinical expertise at the hospital. It's one phone number where it's staffed by a senior nurse who can then direct the calls accordingly. We have an external service facilitator who is there for most days of the week, and our contact number is 31396896 if anyone would like to know that. We are here to work with the general practitioners, and we come in at their behest with their permission. They know their patients best, and sometimes their management plans are far superior than what we can provide. And if they are asking for our help, we are more than happy to come in and support them. We will deal with many infections that are commonly associated with catheters, like urinary tract infections, lung infections, pneumonias, metabolic abnormalities like sodium or potassium. These electrolytes can be sometimes high or low, and we can help with that. We can help with kidney diseases. We can help with behavioral disorders that may be related when they are unwell. There may be simple things that could be precipitating that, and we can assess that and come up with a sensible management plan and follow up, thus treating them in their environment, reducing the risk of falls which is present in an unfamiliar environment. We have formulated a plan where we will take referrals from QAS, as because they would come and assess that patient and would be facilitating transfers. But if they feel in their expertise that this patient can be managed by the outreach service, we will come in at that and liaise with the GP in terms of what management plan we do. It may be in the form of either a phone call or a follow-up letter, depending on what the circumstances are. Can I take the opportunity to just introduce my team, because that's the one you will be seeing more. I'm just the face behind the scene. I'd like to introduce our external service facilitator, Veronica Thompson. Our clinical nurses, Madhulata, Jane Lee, and Leena Prasad. Where's Jane?
She's just gone out to take a phone call.
She's taking a phone call, our third nurse. And our current registrar, Yulia. I must also thank Rosalie Trent, who has been part of the background, working hard in getting this service started. Rosalie was covering for Veronica while she was on leave and has put in many, many hours and endured many grey hairs from me. Rosie? These are the wonderful people who do all the lovely work. I just get the credit for it.
Well, the service was so quick and so definitive that I was sort of recovered within 24 hours, and I'm assured that I was very much in need of the service at the outset. So, I'm very grateful for it. I think it's a wonderful service. And will be of assistance to a lot of people.